SARS meet for this year. Today we have got 5 oral presentations and 3 poster presentations from Department of Medicine, Surgery and Pathology. I take this opportunity to welcome Dr. R.M. Potekar, Professor of Pathology, who will be chairing today's session. Welcome to you, sir. Kindly occupy the chair and take over the proceedings.
Good evening to all the members of SARS who have joined online and the presenters for today's session. I take this opportunity to thank the SARS organizing team for inviting me to chair this today's session. So in today's session we have got 5 oral presentation and 3 poster presentation, mainly from the Department of Medicine, Department of Surgery and Department of Pathology. So to start, I will invite Dr. Sugandha Reddy, PG Department of Medicine, to start his presentation on study on serum magnesium levels and its correlation with HbA1c levels in patients with type 2 diabetes mellitus. Over to you, sir.
कौन सा सर?
So good evening to all. I welcome all the members of SARS for today's session. We will start with today's session with Dr. Sugandha Reddy, PG Department of Medicine. He will start his presentation on study on the magnesium levels and its correlation with HbA1c levels in patients with type 2 diabetes mellitus. Over to Dr. Sugandha Reddy.
Good afternoon, everyone. Today, my presentation topic is on a study on serum magnesium levels and its correlation with HbA1c levels in patients with type 2 diabetes mellitus. This is my agenda for the topic. Coming to introduction and need for the study, with the increasing prevalence of diabetes mellitus globally, it is estimated that 6.9 crore of Indians are diabetic, and with estimated 7.7 crore Indians have pre-diabetes, and 41.5 crore people globally are diabetic. And in that, predominantly 90% of the diabetic population is of type 2 diabetes mellitus. In the diabetes is a metabolic disorder where the trace element hemostasis is which is very much essential for various cellular metabolic reactions, which is impaired. Magnesium is essential cofactor for more than 300 enzymes, and it is a vital cofactor in enzymes involved in glucose metabolism. Magnesium has a role in production and action of insulin. Hypoglycemia is associated with increased intracellular calcium, which could lead to insulin resistance, which is the main pathology in type 2 diabetes mellitus. Hence, it is a need of the hour to investigate for magnesium levels, serum magnesium levels in diabetes, which could be cheaper and safe possible dietary intervention to control this pandemic of diabetes. Coming to the objective of my study objective is to assess the level of serum magnesium levels in the type 2 diabetes mellitus patients and to correlate that with the HbA1c levels. This is a cross-sectional study done over a period of from November 2018 to June 2020. 150 patients of type 2 diabetes mellitus who are qualifying after applying inclusion and exclusion criteria, HbA1c and serum magnesium levels were estimated and then correlated. Coming to inclusion criteria, patients who are newly diagnosed or already on the treatment of type 2 diabetes mellitus are included. Patients who are not on trace element and vitamin supplements in the past 3 months are included, and both the genders, including whose age is more than 25 years of age. Coming to exclusion criteria, patients who are on vitamin and mineral supplements and proton pump inhibitors, loop diuretics and thiazide diuretics, renal disorders and pregnant females, and use of antibiotics like aminoglycoside, amphotericin, vancomycin and digitalis in past 1 week, and patients who are admitted with diarrhea, steatoria, inflammatory bowel syndrome, Whipple's disease, acute MI, malabsorption and pancreatitis, and patients who are undergoing blood transfusion and patients who are having anemia are excluded from the study. In this study, serum magnesium of less than or equal to 1.7 milligram per deciliter is taken as hypoglycemia, and HbA1c values are grouped. Patients of type 2 diabetes are grouped into 4 with the HbA1c values 4 to 6, 6.1 to 7, and 7.1 to 8, and more than 8. Data was entered in Microsoft Excel, and SPSS software was used for analysis. Coming to observations and results, majority of the population are over 40 years, and 40% of population is of more than 60 years, and 48.87% of study population are included in are of 41 to 60 years of age. Coming to gender distribution, majority 66% of the study population was males. And coming to HbA1c levels, in this 150 patients, 58.7% of patients were having HbA1c of more than 8, which indicates poor control. And in this 150 patients, majority of the patients were having normal magnesium levels, but 16.7% of patients of type 2 diabetes mellitus patients are having hypomagnesemia. This is correlation curve, which shows the slight slope towards the right, this is correlation between serum magnesium levels and HbA1c levels. When compared with magnesium levels with HbA1c, patients with lower magnesium levels were having higher mean HbA1c values. patients we are having lower hypomagnesemia, that is less than 1.7 milligram per deciliter of magnesium in serum. In serum, we're having 9.92%, 9.92 HbA1c as mean, and with patients with, and it is negatively correlated. Coming to discussion, in my study, the patients having hypomagnesemia were the prevalence was 16.7%, which is in accordance with the with the Indian studies in Guwahati Medical College, which has been done. The study has been done in 2014. 11.33% was the prevalence of hypomagnesemia, and in Delhi 2017 one study has been conducted. The prevalence was found to be 44%. When correlating HbA1c levels with the serum magnesium levels, my study was showing negative correlation, but statistically it is not significant. When compare in HOMA IR, that when insulin resistance was compared to serum magnesium levels, it was negatively correlated, but it is not significant. Earlier studies were 50%. According to the review of literature, 50% of studies nearly were showing negative correlation, and 50% were showing no correlation at all. Coming to discussion, in our study, it is observed that a negative correlation was found between serum magnesium levels and HbA1c levels, which is statistically not significant, which is likely due to smaller sample size and not taking into the account of duration of diabetes and the patient's oral hypoglycemic agents. Lower serum magnesium levels are prevalent in type 2 diabetes mellitus. Type 2 diabetes mellitus has been concluded in my study with negative correlation with the glycemic control. In the view of negative correlation, which is not statistically significant, routine measurement of serum magnesium levels is not recommended as of now, but could suggest diet. But in patients with having poor glycemic controls, in spite of our medical and lifestyle management efforts, serum magnesium supplements can be orally advised. Further studies with larger study sample and considering duration of diabetes and usage of metformin, pioglitazone and clenagliflozin are advised, because in pioglitazone and clenagliflozin are thought to be increasing serum magnesium levels, thereby affecting the insulin resistance and having better glycemic controls in type 2 diabetes mellitus patients. And in metformin, with long-term use of metformin, patients are having the effect of metformin is found to be decreasing because of its effect on serum magnesium, which is most of the patients may go into hypomagnesemia. Thank you.
The topic is open for the discussion. What is the message you want to give? Okay, all patients with type 2 diabetes, you want to do serum magnesium level.
As of now, it is not, because it is statistically not significant, sir. There is every chance only 16.7% is prevalent, sir. So normal magnesemia was prevalent, sir. 70% of the study population was having normal magnesemia only, but most of the patients were having poor glycemic control levels, HbA1c level.
What happened to those who are hypomagnesemia? What was the glycemic control?
Mean HbA1c was higher in hypomagnesemic patients, sir, and even in the normal magnesemia patients, on correlation there was negative correlation only with the.
So you don't want to recommend the magnesium levels?
No, sir, as of now, no. But in Jigajig University in Egypt is already, there is interim study which is going on now, sir. They are doing it in type 1 diabetes mellitus. Along with the insulin, they are giving magnesium supplement also to have a higher level of serum magnesium levels above than normal. And they are expecting for that.
So why do you expect hypomagnesemia in patients with diabetes?
Sir, this mineral metabolism is impaired, one thing, sir, and in gastropathy, in long-term duration of diabetes, there is diabetic could be possibility will be there, and 50% of only 50% of magnesium which is consumed will be absorbed at any point of time, even though the patient is in hypomagnesemia. So that could be the possible reason for hypomagnesemia.
The cause for hypomagnesemia in patients with diabetes is the osmotic diuresis. Osmotic diuresis will happen in case of diabetes. That's why you expect that it could be decreased magnesium levels in diabetic patients. But still it doesn't happen. So what would be the reason? What are the other mechanisms for hypomagnesemia can be there in diabetes?
Reason for normomagnesemia in my study.
Did you understand the question?
No, sir.
So we expect the hypomagnesemia because there is an osmotic diuresis.
Yes.
Where along with water the minerals also will be lost.
Yes.
But in this study you are not getting that there is a hypomagnesemia in most of the cases of diabetes.
Yes.
That is not there in your
Not
case.
there in my study.
So what was the reason? What could be the probable reason why there is no hypomagnesemia?
Sir, vitamin supplements I have taken history orally, and prescriptions they have bought already. They were based on the history of not taking mineral and vitamin supplements only I have taken. So patients would have taken any mineral supplement which could have resulted in acute rise in which making the patient normomagnesemia in my studies.
Because magnesium levels, the main factor which maintains the magnesium level
Is absorption and renal parameters.
renal and others are the hormonal, other hormones. Magnesium level. So they will try to correct the whatever the magnesium loss is there due to osmotic diuresis. That will be corrected. Okay. By the corrective mechanism. So even though you expect to be decrease in the magnesium levels, actually doesn't happen because of the corrective mechanism which is there. Okay. Thank you.
Is there a relation between duration of diabetes and magnesium? Because as Sir told, this correction mechanism is going on. How long it is? Suppose 15 years for diabetes. The patient is 15 years of diabetes. Can he have any electrolyte disturbance or magnesium?
Patients having long duration of in the discussion part, there are few studies which are showing that patient having long duration of diabetes with diabetic nephropathy or neuropathy are having higher prevalence of hypomagnesemia.
As far as kidney functions are retained, there is a compensating mechanism that takes place in our body. That's why you find a normal magnesium. Once the renal failure or nephropathy sets in, you are likely to lose more magnesium.
Okay. Thank you for your presentation. Second presentation is by Dr. Radha Banerjee. Topic is evaluation of D-dimer level in predicting the severity of acute pancreatitis and early assessment of organ failure.
Good afternoon, everyone. I'm Dr. Radha, PG of Department of General Surgery, and I'm presenting a paper today, which is the evaluation of D-dimer in predicting the severity of acute pancreatitis and early assessment of organ failure under the guidance of Dr. M.B. Patil, Dr. Ramakant sir, and Dr. S.S. Patil sir. Acute pancreatitis is a relatively common and a potentially life-threatening disease. It's defined as an inflammatory process of the pancreas with possible peripancreatic tissue involvement and multi-organ dysfunction syndrome with increasing mortality rate. Incidence is inaccurately estimated most of the times, as mild cases are unreported and severe cases lead to death before diagnosis. Mild acute pancreatitis can be distinguished by self-limiting interstitial edema of the gland, and 20% of them are having severe form, which is associated with complications such as pancreatic necrosis, pseudocyst, and distant organ failure and hemorrhage. The mortality in mild cases is 0 to 1%, whereas it's 15 to 30% in severe form. D-dimer with a molecular weight of 180 kilodaltons is a final product of fibrin degradation, a small protein fragment present in the blood after the clot is degraded by fibrinolysis. It consists of remnants of all three chain alpha, beta, and gamma, which are linked by disulfide bonds. It's named so because of the two D fragments, which are cross-linked by a fibrin protein. It is mostly used as an effective diagnostic tool in pulmonary embolism, has been reported to have a great predictive power in the early phase of acute pancreatitis. The mechanism of increase is formation of multiple intravascular thrombi and consequently process of fibrinolysis. Its concentration were measured at admission after 48 and 72 hours, were an accurate method for identification of patients who would develop organ failure in future. A normal D-dimer level was less than or equal to 500 nanogram per ml fibrinogen equivalent units. This was a prospective study for all patients admitted with a diagnosis of acute pancreatitis in BLD Sri B.M. Patil Medical College. The study period was from November 2018 to July 2020. All characters were summarized descriptively. For continuous variable, standard deviation was used, and for categorical data, the number and percentage was used, and diagrammatic representation was done. Out of 115 patients enrolled in this study, 105 were males and 10 were females, with a peak age noticed in third to fourth decade. The peak age for males was 41 years and that for females was 39 years. Most common etiology in our study was gallstone disease followed by alcohol, and in decreasing order it was trauma, hypertriglyceridemia, drug-induced, and idiopathic. This chart shows the association of D-dimer from day 1, day 3, and day 5 with definite as well as moderate association. As we can see, from day 1, day 3, day 5, it goes on, the values go on increasing, which shows that there is increased association of D-dimer. Also, I have compared my study with SOFA, Apache, and Ranson score, which can predict the organ failure in future. Most of the values are coinciding with the other studies. D-dimer shows a sensitivity of 94% with a specificity of 86%, which is much higher than that of the other three studies which are traditionally done. Out of 115 patients, 96 patients presented with mild acute pancreatitis and 19 with severe. Of the 96 of mild group, 1 presented with organ failure and no mortalities in this group. Of the 19 patients with severe group, 5 developed organ failure and 2 deaths. Acute pancreatitis is associated with very high morbidity and mortality. Early diagnosis and prompt treatment would help in preventing unnecessary deaths. A relatively simple parameter, D-dimer, was used to predict the severity of acute pancreatitis. It was also used to predict the occurrence of organ failure. According to this set cutoff in our study, 84% showed definite association and 15% showed moderate association with the disease. The value of D-dimer shows an increasing trend from day 1 to day 5, which is suggestive of increased association with severity. This has been compared to a similar study done in the past by Anil Kumar et al. According to the area under curve of each parameter, we have also seemed to have predictive power similar to that of Apache 2 and Ranson's. Conclusion, I would conclude by saying acute D-dimer has a good predictive power in early phase of acute pancreatitis. Also because of widespread availability, has an advantage in clinical practice as well as in emergency conditions. It has more sensitivity, specificity, and more diagnostic accuracy. Hence, it is found to predict more number of patients with and prevent them for going to likelihood of severe disease. These are my references. Thank you.
The topic is open for the discussion. Now, can you elaborate a little more about that SOFA score and Ranson score? What is that?
SOFA score is a sequential organ failure assessment, sir. It includes different parameters based on which we decide whether the patient is, this is only for ICU admitted patients. Based on their hematocrit levels or saturation levels, we decide if the patient is going into organ failure or not. And this has correlated with the D-dimer levels, which we have done on admission as well as day 3 and day 5. Similarly, for Ranson score, only at admission, we do at admission and after 48 hours, sir. This is also predicting power of Ransom score is much less as compared to our study. It shows a sensitivity of only 51%, where D-dimer only a single parameter, which shows a sensitivity of 94%. And Ransom's has multiple parameters. It has 10 parameters, of which 5 are done on day 1. And this can vary in different patients if they have a past any medical history.
So what was the diagnostic criteria that was used to diagnose pancreatitis?
Diagnostic criteria was elevation in serum lipase and amylase levels, and clinically, patient with a pain abdomen, sir. For diagnosis, we just use amylase and lipase levels on admission.
There are no questions. We will move to the next presentation. Thank you, madam.
Thank you, sir.
Next presentation is from the Department of Pathology, Dr. Anurag Sajjan. We will be presenting on study of lung weight, body weight ratio, and radial alveolar count in fetal adults.
Good afternoon, everyone. My topic is study of lung weight to body weight ratio and radial alveolar count in fetal autopsies. Introduction. Pulmonary hypoplasia is one of the commonest causes of neonatal morbidity and mortality. The incidence of pulmonary hypoplasia is 9 to 11 per 10,000 in the general population, and its reported prevalence in the perinatal autopsy is between 7.8% to 26%. Pathologically, pulmonary hypoplasia is defined as decrease in lung weight to body weight ratio and radial alveolar count during postpartum examination. As per Ashkenazi and Perlman guidelines, lung weight to body weight ratio less than equal to 0.012 and or radial alveolar count less than or equal to 4.1 was taken as diagnostic criteria for pulmonary hypoplasia. Aims and objectives: to determine the relative frequency of pulmonary hypoplasia in fetal autopsy cases by evaluation of lung weight to body weight ratio and radial alveolar count. Materials and methods. A prospective observational study was done on 31 cases of fetal autopsy specimens received in the Department of Pathology from December 2019 to June 2020. External examination, anthropometric data of fetus and grossing were done as per standard format of fetal autopsy study. Evaluation of pulmonary hypoplasia was done in all cases by lung weight to body weight ratio and radial alveolar count. Results: a total 31 cases were studied. Lung weight to body weight ratio and radial alveolar count was done in all cases. Lung weight to body weight ratio evaluation showed that 13 cases had lung weight to body weight ratio less than 0.09. 6 cases had between 0.010 to 0.012. 5 cases had lung weight to body weight ratio between 0.013 to 0.017, and 7 cases had lung weight to body weight ratio more than 0.018. This is the graph showing the distribution of the cases, that in 13 cases less than 0.09, 6 cases between 0.010 to 0.012, 5 cases between 0.013 to 0.017, and 7 cases more than 0.018. In 13 cases where lung weight to body weight ratio was less than 0.009, the radial alveolar count was done, and it was found that it was less than 4.1, thus supporting the diagnosis of pulmonary hypoplasia. In 6 cases where lung weight to body weight ratio was between 0.010 to 0.012, but RAC was found to be more than 4.1. In 5 cases, where the lung weight to body weight ratio was between 0.013 to 0.017. However, the radial alveolar count was found to be less than 4.1. In 7 cases, where the lung weight to body weight ratio was more than 0.018, and here RAC was done, and it was found to be less than 4.1 in 6 cases and more than 4.1 in 1 case. So we conclude that total cases, that is 24 cases, had RAC, that is radial alveolar count, less than 4.1, in which 13 cases had lung weight to body weight ratio less than 0.009. 5 cases had between 0.013 to 0.017, and 6 cases had lung weight to body weight ratio more than 0.018. So this is the graphical data showing the radial alveolar count. Here we can see a total of 24 cases showing RAC, that is radial alveolar count, less than 4.1. So the categorization of the cases were done as per clinical and histological diagnosis, and the comparison was done between lung weight to body weight ratio and radial alveolar count. Here we can find that the lung weight to body weight ratio with a p-value of 0.08, which was insignificant when compared with the radial alveolar count, which has a significantly high significant value of p-value, that is 0.03. And our results were in concordance with the study by Ashkenazi and Perlman M, which showed that the RAC, that is radial alveolar count, was more reliable criteria for pulmonary hypoplasia. These are the few images showing the gross anatomical deformity. The figure one shows the unilateral renal agenesis, where the kidney is in the pelvic cavity. Figure 2 shows the image of anencephaly, that is frog-like faces. Figure 3 shows the image of congenital cystic adenomatous malformation, and figure 4 shows a picture of gross ascites with cystic hygroma. This is the image showing the how to do radial alveolar count. So it is done by the perpendicular line drawn from the center of the respiratory bronchial to the connective tissue septum, and the number of alveoli are found by the line transferring from the center of the respiratory bronchial to the connective tissue septum. The figure 5 shows the radial alveolar count, that is found to be 3. And figure number 6 shows the radial alveolar count, that is found to be 1. Discussion. Study done by Agabiklu et al. Over the period of 24 years in 850 perinatal autopsies showed that the incidence of pulmonary hypoplasia in perinatal autopsy was 11.3%. In our study, 24 cases out of 31 were concluded as pulmonary hypoplasia, and in all cases, the diagnosis of pulmonary hypoplasia was incidental finding. 90% of etiologies of pulmonary hypoplasia were due to secondary pathology, that is outside the respiratory tract. Our study showed 62.2% of pulmonary hypoplasia cases had secondary etiology. Conditions associated with pulmonary hypoplasia were anencephaly in 6 cases, oligohydramnios in 4 cases, renal agenesis in 2 cases, and 1 case each of congenital cystic adenomatous malformation, gastroschisis, and ascites. Conclusion: based on the combined evaluation of lung weight to body weight ratio and radial alveolar count, the number of cases diagnosed as pulmonary hypoplasia were more as compared to evaluation of lung weight to body weight ratio alone. Hence, we conclude that radial alveolar count was more reliable criteria for pulmonary hypoplasia. These are my references. Thank you.
The topic is open for the discussion.
Madam, what is the take-home message?
Sir, pulmonary hypoplasia was incidental finding and it can be considered in unexpected death, and it can be an incidental finding even in the routine fetal autopsies what we get during examination for fetal. It can be even incidental finding in routine fetal autopsies.
Okay. Now, what message you want to give it to the, while, is there any, is going to be a tool for pre-diagnostic tool, something like that, so that you can advise?
Nowadays, these radiological investigations usually diagnose these pulmonary hypoplasia by USG, MRI, CT scans, even this bronchoscopy and the pulmonary angiography, even these are used for the diagnosis of pulmonary hypoplasia.
Yeah.
This autopsy will add on the diagnosis of the already diagnosed pulmonary hypoplasia.
Okay, for correlation, right?
Yes.
Okay, okay. Okay, thank you.
If there are no questions, we'll move on to the next presentation. Fourth presentation is by PG from the Department of Surgery, Dr. Firoz Khan, amniotic membrane of boon for burns patients.
Good afternoon. Myself, Firoz Khan, PG from the Department of Surgery. I am presenting a paper on amniotic membrane, a boon for burns patient, under the guidance of Tejaswini ma'am, Girish Kulloli sir, and Vikram sir. Coming to introduction, burns are a prevalent and burdensome critical care problem. The priorities focus on stabilizing the patient, preventing infection, and optimizing the functional recovery. Amniotic membrane is used nowadays in burns, nerve regeneration, soft tissue reconstructive surgeries, ocular surgeries, and diabetic foot ulcers. Amnion and amniotic membrane contains growth factors, granulocyte colony stimulating factors, which are responsible in healing and regeneration. Dermal burns are painful, which oozes a lot, soaking the dressings, and are prone to sepsis. Use of amniotic membrane as a biological dressing eliminates pain, reduces oozing, soakage of dressing, and thereby the infection rate. Dressings do not stick to the burn wound, and consequently dressing changes and post-dressing period are painless and so comfortable. Amniotic membrane also contains anti-inflammatory cytokines, tissue inhibitor of metalloproteinase, and stem cells. They lack HLA-A, B, C, or DR antigens and beta-2 macroglobulin, thereby decrease cytokine synthesis and inflammatory response in vivo. Coming to materials and method, it was a prospective study conducted in our college. Burns patients with 10 to 30% first and second degree scald or flame burns admitted under the surgery department were selected. And period of study was between November 2018 to July 2020. And the placenta was collected from healthy mother without any torch infection, hepatitis B, C, or HIV and syphilis infection, who underwent either vaginal or cesarean section from the obs and gyn department. Coming to harvesting the amniotic membrane, 2 trays were taken for the preparation of amniotic membrane. The semi-transparent amniotic membrane was separated and removed in toto in the first tray from the placenta. It was washed in the normal saline solution such that all clots and the debris were washed away. In the second tray, gentamicin solution was prepared. It was prepared by adding 5 ampules of gentamicin, each containing 80 mg to the 1000 ml of normal saline. The amniotic membrane was carefully transferred to the same and preserved for 6 hours. After 6 hours, the burned area was thoroughly cleaned with normal saline and the amniotic membrane carefully placed over the area, and the dressing with plain pads were done. The dressing were removed after 48 hours and the pain score was assessed. Conventional dressing was done with, in the conventional group, dressing was done with silver sulfadiazine and Cuticel and changed on the daily basis or alternate day based on assessment. Patients were discharged on fit and followed up in the OPD. We used statistical analysis and SPSS software to analyze the results. These were the results we got. The mean age group in the amniotic membrane group in our study was 18.9 years, whereas in the conventional group it was 30.9 years. Coming to the hospital stay in the amniotic membrane group, the mean hospital stay in the amniotic membrane group, it was found to be 13.2 days compared to a hospital stay of 19.7 in the conventional dressing group. And coming to the number of dressings, it was found to be a mean of 1.4 in the amniotic membrane group, whereas it was 15.1 in the conventional dressing group. And the mean pain score which was assessed on the day 1 and day 3. Day 1 pain score was almost equal in the two groups, whereas the day 3 pain score which was in the amniotic membrane group was 3.5 compared to 7.6 in the conventional dressing group. And time for epithelialization, it was found to be 14.5 days on an average for the amniotic membrane group and 21.6 days in the conventional dressing group. These are the images of two patients where we used amniotic membrane dressings. This is the patient with where we use the conventional dressing. Coming to the discussion, burn wound management is always a clinical challenge to the practitioners. With the aim of tackling this, our study was conducted on a total of 70 patients who had 10 to 30% total body surface area, first to second degree burns. 36 patients in the study had amniotic membrane dressing, whereas 34 had the conventional dressing. And pain score, as already discussed, it was found to be 8.8 on an average of in the amniotic membrane group and 8.7 in conventional group. It was found to be non-significant, whereas the day 3 pain score was significantly less in the amniotic membrane group. And the time for epithelialization was found to be 14.5 days on an average in the amniotic membrane group and in 21.6 in the conventional dressing group. And hospital stay, it was found to be 13.2 on an average for amniotic membrane group, whereas it was 19.7 in conventional dressing group, implying that the patient who received the amniotic membrane dressing had relatively less number of hospital stay. We compared our study with studies conducted by Sani, where they compared regarding the time for epithelialization, which was found to be significant in amniotic membrane group. And Mohammadi et al. Also conducted the same study where they assessed for the pain score, hospital stay, time for epithelialization, all these three parameters, and that also was found to be significant. And Mohammadi et al. Conducted with Sabath conducted a study which assessed pain score and time for epithelialization and time for epithelialization, and that was also found to be significant. In our study, we found that day 3 pain score was significant, and hospital stay significant reduction in hospital stay, and time for epithelialization was faster and less number of dressing. Coming to the conclusion, in our amniotic membrane group, there was significant reduction in the number of dressing, almost one dressing, and the pain and hospital stay was significantly less. Wound healing was faster in terms of epithelialization, reduced hospital stay, faster wound healing, less number of dressing, and reduced infection rate indirectly reduced the financial burden of the patient. These were my references. Thank you.
The topic is open for the discussion. My question is whether you will suggest this amniotic membrane dressing for all the cases of non-healing wound, or it is only for burn patient use?
Only for burns patient. There are trials are there, sir. In the wounds, there are trials going on where the criteria is the wound should be sterile. Most of the times, if the wound is contaminated with deep ulcers and all, the take-up will be difficult. Even then, trials are going on for the use in ulcers, other wounds.
Thank you.
Thank you.
We'll move on to the next presentation. The next presentation is from the Department of Medicine, Dr. Pranay Kumar. He will be presenting on the study of clinical and radiological profile of sputum positive tuberculosis among elderly patients.
Good evening to one and all present here. My topic for today's presentation would be a study of clinical and radiological profile of sputum-positive tuberculosis among elderly patients under the guidance of Dr. Anand Piambali. Need for the study: tuberculosis, as we know, has forever been known to mankind to cause mortality and morbidity. The disease has been extensively studied in the younger population to present with the typical symptoms and the typical radiological features, but has rather not got the importance it deserves in the elderly. Now, this happens because of a few reasons. One so being atypical presentation, which I will discuss further. Secondly, being the scanty sputum production and hence not having the availability or the options to test the sputum for the tuberculosis, and the associated comorbidities, which also I will present, masking the particular symptoms that these patients in this subset of the population present with. And hence the objective of the study was to study the various patterns of presentation of the sputum-positive pulmonary tuberculosis in the geriatric population and to study the radiological features in the same subset. Coming to materials and methods, the cases were selected from those patients who were aged above 60 years, attending either the medicine outpatient department or who were admitted in the wards of Shri B.M. Patil Medical College Hospital. The sample size was 70. Inclusion criteria included all patients, which is elderly patients aged above 60 years who were who tested positive for the sputum acid-fast bacilli, and which was also irrespective of the category of the treatment that they were taking. And exclusion criteria was patients with radiological features suggestive of tuberculosis, but who were sputum negative. Observations: age-wise distribution of the patients. Our study showed that maximum number of patients were aged between 60 to 65 years. That's about 48.6% of the population. The youngest of the population that I considered was 60 years, and the oldest being 92 years. Gender-wise, males predominated the study with about 80%, and females were only 20% of the population. Coming to distribution of patients according to the duration of the symptoms, most of the patients presented to us within the first 1 to 4 weeks of the symptomology, followed by 3 months and 4 months. While 47 patients, that is about 67.1% of the study, presented with the typical symptoms of chest pain, hemoptysis, and cough, 23 patients, that's about 32.9% of the patients, presented with the atypical presentations, which I will discuss further. Coming to the distribution according to comorbidities, 54.3% of the population did not have any known comorbidities, but hypertension led the study in terms of comorbidities, with 12.9% having hypertension alone, and also hypertension was associated with other diseases like ischemic heart disease and diabetes mellitus. Chronic obstructive pulmonary disease and diabetes mellitus were also seen to be the known comorbidities. Coming to distribution according to the Zeal-Nielsen stain pattern, according to the ZN stain, most of the patients that were studied fell under the 3+ and the 2+ category, and very less among the scanty and the 1+ categories. Coming to distribution based on radiological features, in our study, miliary mottling constituted the maximum, that is about 21.4% of the patients had miliary mottling, followed by pleural effusions, consolidation in the form of pneumonia, and followed by fibrosis, and then cavitation and calcifications. Among our study, HIV was tested as a co-infection in tuberculosis. 71.4% of the patients were tested negative for HIV, whereas 12.9% of the population tested positive for HIV, along with as a concurrent infection with tuberculosis. Discussion. So in comparison to the other studies, respiratory symptoms, that is the typical respiratory symptoms like cough and hemoptysis, were present in about 92% and 74% in the other studies. In our study, cough was present in 67.1% of the cases, hemoptysis in 4.2%, dyspnea in 35.7%, and chest pain in 22.8% of the cases. The constitutional symptoms, as we can see in comparison to the other studies, fever was present in 57.5% and 74% in the other cases. It was present in 47.1% in our case. The major atypical finding in our study was noticed to be weight loss and loss of appetite, which was present in 88.6% of the cases, which was present as 80% and 80% in comparison to the other studies. The radiological features, as in our study, the miliary mottling was present as a maximum for 21.4%, whereas the other studies showed about 6%. Infiltrates and consolidations dominated the other studies, whereas in our study, middle and lower lobe infiltrates were present in 17.1%. Our study did not include the presence of any upper lobe infiltrate, which is usually a feature of the tuberculosis in the younger population and quite against the feature of elderly tuberculosis. In similarity with the other studies, diabetes mellitus and hypertension and COPD were the leading comorbidities in the other studies as well, which was present in our studies also. In a study done by Ji Ho Lee et al., 81 out of the 81 geriatric subjects studied, 71 completed the treatment course, and 10, that is 12.3 patients expired during the study. In our study, 7 patients were defaulters who did not complete the full course of the therapy, and 5 were relapses who had come positive again after completing the course of therapy. In our study, 8 patients died during their hospital stay while being studied, which summed up to about 11.4% of the mortality among the study subjects. And the most common cause of death was type 1 respiratory failure, owing to the underlying pulmonary conditions. So conclusion, a significant number of patients presented with atypical presentation. The most common feature among them was weight loss, followed by fever and night sweats among the elderly patients. Miliary remodeling was the most common radiological feature. And nowadays, widespread availability of CBNAT has made the diagnosis of tuberculosis more extensive. These are my references.
The topic is open for the discussion. In your study, what was the commonest radiological finding? That is
miliary remodeling, sir, was the most common radiological finding in our study.
Any case where there was no radiological finding, but sputum positivity was there?
Not really, sir. Minimal findings, at least infiltrations were there, sir, in any of the study. I could not record among the 70 patients that I have taken among the geriatric population. At least infiltrates were there minimally in the middle and the lower lobe, sir. At least not so much so in the upper lobe, but at least minimal infiltrations were present in most of the patients that I had considered.
Any other questions from the audience? There are no questions. We'll move on to the next presentation. Next, we'll go to 3 poster presentations. First one is from the Department of Surgery. That is brachial plexus schwannoma rare case report by Dr. Sushma B.
Good afternoon, everyone. Today I'll be presenting a poster on brachial plexus schwannoma, rare case presentation under the guidance of Dr. Vijay Patil Madam and Dr. Deepak Sir. Coming to introduction, schwannomas are a benign nerve sheath tumors arising from the Schwann cells. 25 to 45% or 40% of all the reported schwannomas are seen in head and neck region. Brachial plexus schwannomas are a rare entity and it accounts for only 5% of all the schwannoma cases. A common clinical presentation includes a palpable mass, pain, paresthesia, weakness, and numbness of the limb. I'm presenting a case of 58-year-old male who presented with swelling in the right side of the neck since 6 years, insidious in onset and gradually progressive, which was not associated with pain, paresthesia, dysphagia, dyspnea, change in voice, cough, or loss of appetite, or significant loss of weight, and there was no history of similar swellings in other parts of the body. On examination, it was a globular swelling of 4 into 5 centimeters in right supraclavicular region in posterior triangle of the neck. Borders were well defined and skin over the swelling was normal, firm in consistency, which was non-tender, mobile in horizontal direction, and the plane of swelling appeared to be below the deep fascia and the swelling was non-pulsatile. FNAC was suggestive of benign spindle cell tumor, and MRI showed well-defined encapsulated lesion of 4 into 4.5 centimeters deep to the scalene muscle, which was suspecting to be arising from the upper trunk of the brachial plexus, and all the routine investigations were done. This is a picture of MRI. The surgical procedure was carried out under general anesthesia by the anterior approach. A linear incision was taken over the mass. A well encapsulated lesion of 4 into 4 centimeters was noted in scalene triangle just above the clavicle and deep to the scalene muscle, lateral to the carotid sheath. The swelling was arising from the upper trunk of brachial plexus. Complete enucleation of the swelling was done, preserving the nerve and the nerve sheath. Post-operatively, there were no signs of neuropraxia, sensory and motor dysfunction. HPR was suggestive of schwannoma, showing hypercellular Antony A areas and hypocellular Antony B areas. This is a preoperative picture showing a hemispherical mass in the right supraclavicular region. This is an intraoperative picture showing a well-encapsulated tumor. And the first picture shows the tumor is arising from the brachial plexus. And this is after complete excision of the tumor. There is no residue of the tumor after excision. Coming to discussion, brachial plexus tumors are uncommon, comprising only 5% of upper limb tumors. The most common benign peripheral nerve sheath tumor arising from the brachial plexus is neurofibromas. Schwannomas are second most commonest peripheral nerve sheath tumors, of which only 5% arise from the brachial plexus. Schwannomas are benign, slow-growing tumors arising from the nerve sheath with neuroectodermal origin. Schwannomas arising from the brachial plexus is a diagnostic challenge for surgeons because they can be easily misdiagnosed as enlarged lymph nodes due to the rare incidence and the complex anatomical location. Schwannomas are well circumscribed lesions which are isotense on T1 and hyperintense with strong enhancement of T2 on MRI, and also able to evaluate the direct association between tumor and the parent nerve. It is difficult to evaluate this direct association in USG, hence MRI is the investigation of choice, and enucleation is the first surgical treatment of choice, and complete resection of the tumor with preservation of the nerve sheath is the ideal goal. Intraoperative neuromonitoring facilities facilitates the identification of the nerve and minimizes the trauma to the nerve during the dissection. Complications reported in most of the cases are temporary motor and sensory deficits. Schwannomas are radioresistant and the potential for malignant changes are extremely rare. Conclusion, schwannomas of brachial plexus is a rare entity, usually present as palpable, slow-growing swellings in the neck and are usually symptomless. However, surgeons should keep schwannoma in mind as a differential diagnosis when a patient presents with long-standing, well-encapsulated swelling in the posterior triangle of the cervical region. Enucleation is the treatment of choice with preservation of the nerve sheath continuity. These are my references. Thank you.
The topic is open for the discussion. Any queries from the audience? So there are no queries, so we'll move on to the next presentation. Thank you, Dr.
Thank you, sir.
Next presentation is from Dr. Payal Doctor, PG, Department of Pathology. The topic is diagnostic dilemma in renal transplant COVID positive patient.
Good evening, everyone. Topic for my poster presentation is diagnostic dilemma in renal transplant COVID positive patient, a case report. I'm doing it under the guidance of Dr. Satish sir. Starting with the introduction, COVID-19 infection is caused by SARS-CoV virus and is responsible for the pandemic in 2020. Most common signs and symptoms include fever, cough, lower respiratory tract infection, etc. Mortality in COVID-19 is most common in elderly individuals with comorbid conditions like diabetes, hypertension, myocardial infarction, etc. Hereby, we are presenting a rare case report of COVID-19 infection in a renal transplant patient. Coming to the case report, a 51-year-old male patient, a known case of diabetes, hypertension, and chronic renal disease with renal transplant 3 years back and on immunosuppressive drugs, was admitted in the ICU. His chief complaints were high degree fever, myalgia, fatigue, abdominal pain, moreover to the left upper abdomen. On examination, there was tenderness in the left hypochondrium region. Rapid antibody test for COVID-19 positive was positive for both IgM and IgG. On USG abdomen, hypoechoic collection was noted in the inferior pole of the spleen, measuring 5 by 6 centimeter with mild perisplenic collection, suggestive of splenic abscess. On the kidneys, bilateral small kidneys were grade 3 renal parenchymal changes shown. CT abdomen showed spleen showed non-enhancement of spleen, suggestive of splenic infarct. Kidneys were small native kidneys, and bowel showed gaseous distension of the large bowel with minimal fat stranding in the cecal region, mild ascites. And lung showed bilateral basal small focal areas of consolidation with left basal pleural effusion. Investigations done on investigations, neutrophilic leukocytosis were found with anemia and deranged coagulation profile. The provisional diagnosis of septicemia with COVID-19 infection was made, and the patient had undergone emergency laparotomy. Intraoperative findings were gangrenous spleen, omentum, Gerota's fascia, and perinephric fat, and distal pancreas were sloughed out. On gross specimen, the spleen measured 12 by 9.5 by 2.5 centimeter, and cut section showed necrotic appearance. On microscopy, we found diffuse loss of splenic architecture, completely replaced by necrotic tissue, calcified blood vessels, and refractile aseptate broad angle fungal hyphae, suggestive of mucormycosis, and special stain PAS stain was positive. Hence, final diagnosis of mucormycosis infection of spleen was made. Coming on to discussion, mucormycosis is an uncommon and fatal fungal infection. The hallmark of mucormycosis infection is tissue infarction and vascular invasion. Spleen is a rare site for fungal infection. With superadded COVID-19 infection and bilateral basal consolidation in the lungs, the underlying splenic lesion will be confused as a part of thromboembolic episodes rather than fungal infection. Hence, delay in the treatment of antifungal drugs will lead to mortality in such cases. Conclusion, in COVID-19 infection, the rare manifestation of fungal infection to be considered while treating the immunosuppressive patients. Thank you.
The topic is open for the discussion. If there are no queries, we will move on to the next presentation. Next presentation is from the Department of Surgery, Dr. Manoj J. We will be presenting on a rare case of penetrating head injury.
Good afternoon, one and all present here. Warm greetings from Department of General Surgery. Here is a case of penetrating head injury. Penetrating head injury is very rare in case of head injuries. Traumatic head injuries includes various ranges of pathological injuries, and these penetrating head injuries will be having poor prognosis. Hereby, I am reporting a case report with a 21-year-old patient. While working in a construction site, he lost his balance and fell onto a erected iron rod by sides of the step, and he was stuck into it. Bystanders helped him to pull out from the rod, and they saw the bleeding from the mouth, and subsequently the patient became unconscious. In emergency medicine, in the emergency ward, the patient was received in an unconscious state with GCS of 7 with dilated right pupil with left hemiparesis. The vitals were stable. With mild tachycardia. Due to his poor GCS, the patient was intubated, and the CT was done and found to have right-sided intertemporal temporoparietal intraparenchymal hematoma with significant mass effect causing midline shift, more than 6 mm. Hence, the patient was planned for emergency craniectomy with hematoma evacuation. After thorough study of imagology, the rod would have traversed through the soft tissue, entering to the right side of the soft palate, directing superiorly into the paracellular region, perforating greater wing of sphenoid bone, carrying bone spicules along with it through the temporal lobe to the parietal lobe, rupturing the parietal dura and stopping at the parietal dura without perforating the bone. Here is the images showing the blood-stained iron rod at the site of construction and entry wound at the soft palate while intubating the patient. CT image showing the parenchymal window with hematoma showing the midline shift. There are multiple air foci over the soft tissue over the floor of mouth, and bone window showing the fracture of greater wing of sphenoid with the bony spicules over the right side of the parietal lobe, and hematoma with midline shift has been shown. Intraoperatively, after removal of the bone flap, there was dense dura with around 1.5 centimeters perforation with hematoma filling it. The rest of the dura was very tense and durotomy was done, and hematoma was evacuated. Uh, Post-operatively, the patient was kept on 2 days of ventilator. His GCS was E3, V2, VT, and M5 with both pupils reactive and equal with persisting left hemiparesis. The patient was extubated and shifted to step-down ward after 2 days with physiotherapy. The patient was discharged on post-operative day 12 with GCS of E4, V5, and M6 with improving hemiparesis. The patient was called for regular follow-up, and after 6 months of repeat CT was done, the CT shows complete resolution of hematoma with subsided of edema. The patient underwent cranioplasty with autologous bone flap. Now he is on regular follow-up and able to carry out his regular activity independently and walking without support and going for work. Here are the intra-op photos. This is the photo showing the dural puncture at motor cortex with hematoma. And after durotomy, there was a subdural hematoma which was evacuated. And post-craniotomy day 1, this shows a residual hematoma with no midline shift with adequate craniotomy. And follow-up scan of 6 months, it shows the complete resolution of the hematoma, intra-op photo of cranioplasty and post-cranioplasty CT. Discussion: the penetrating head injury caused by foreign bodies other than bullets and shrapnels are extremely unusual. The most common is due to the knife injury, although the craniocerebral perforating injuries have been reported, for example, by nails, metal poles, ice picks, keys, pencils, chopsticks, and power drills. The penetrating injury differs from gunshot injuries as it will not create any cavitations or necrosis or diffuse axonal injuries. Due to the absence of injury to the vital structures like large vessels, the prognosis is favorable in these conditions. The penetrating head injuries is also have the complications like infection, CSF leak, convulsions, focal neurological deficits. The infection is higher in these kinds of penetrating injury if the retained foreign bodies are present. In these cases, the penetrating injuries report 30 to 50% of the patients will be having convulsions. And however, the anti-epileptic treatment will be given for the patients. Vascular complications like the patients will be having vascular complications in penetrating head injury in the range of 5 to 40%. Generally, the patient with penetrating head injury requires prompt medical treatment with the penetrating object has to be removed within 12 hours. Conclusion: we report the first case of accidental penetrating head injury in which is entering through the left angle of mandible, perforating the right soft palate and missing great vessels, entering through the paracellular region through the temporal lobe and injuring the right motor cortex. Timely intubation and adequate surgery has helped the patient to have the better post-operative outcome, and the follow-up after 6 months showed GOS of 5. These are my references. Thank you.
The topic is open for the discussion. Thank you, Dr. Manu, for the presentation. So with this, we have coming to the end of the today's presentation. Over to Dr. Keshav.
That concludes today's meet. Thank you one and all for attending today's